Uh, this presentation was inspired by a recent consensus paper that I had led, and um, I am currently I retired from the Navy and am currently working in the Department of Veterans Affairs. This paper represents the state of the art in laser treatment of traumatic scars. So there are 26 participants, dermatology, plastic and reconstructive surgery, 13 countries from a variety of practice models. So I wanted to mention that Wiley, the publisher of Lasers in Surgery Medicine, had offered the entire special laser scar issue for free download, including this paper. So thank you, Wiley. So one of the take-home points is that lasers are a first-level treatment for scars. And no matter what type of laser device you have something to offer a patient. So in bold and caps, I have listed what I think is a primary goal endpoint for these platforms. And I have in the small case, lowercase, a minor endpoint. And as you can see, the microfractional ablative is our heavy hitter. Macrofractional ablative. So the microfractional is the small diameter beams. The macrofractional is our old school large diameter beams. Fractional non-ablative, vascular and short pulse.
Here. Okay, so you are on the webinar now.
So I wanted to clarify something, and we had a training program in the Navy, and one of the confusing points for them was, what's the difference between active FX, deep FX? And I think one of the great things about a forum like this, normally at a conference, we're not allowed to mention trade names, but I think in a forum like this, we can get specific and really get into some of the details and even some settings. So active FX, deep FX are just different types of pattern generators. Active FX is the old school. So we have these broad and superficially penetrating beams, whereas the microfractional or the deep FX, scar FX, are these deeply penetrating narrow beams. So the active creates an array of millimeter-sized discs that penetrate a couple hundred microns, and the deep FX, scar FX is a little more than 1/10 of a millimeter diameter, and they penetrate several millimeters, up to 3.5 to 4 millimeters. So the old school, we've had the active for a while, and if you are still working with surgeons who say they tried laser and it doesn't work, they may be talking about that. But the reason we're all here is the innovation on the right, the microfractional, these deeply penetrating beams. And you can imagine, just by looking at these patterns, that the biologic effects would be different. And it is this narrow microcolumns, deeply penetrating, that gives us our terrific results. As illustrated on this tongue depressor. So we are just shining photons of CO2 laser light onto skin is not going to magically heal the patient. So these are each handpiece has its own application. When we're talking about traumatic scars, we're most commonly on the second from the left, these deeply penetrating beams that are widely separated with a low density treatment. So high energy, low density, or the HELD for short. So deep FX, scar FX is just software. It lets you tap into different settings. So with deep FX, the 50 millijoules is the maximum pulse energy. It gets you down to about 1.5 millimeters. Scar FX lets you dial in greater pulse energies and the depths up to 3.5. Active FX, again, you can get up to a couple hundred microns. What I want to point out, though, this density setting, different from the deep FX, the density setting is an arbitrary number. Even at the lowest setting, a setting of 1, the density of coverage is 55%. And that's probably too much for the traditional scar. When we use active for as the gold standard for wrinkle reduction, it is healing from the adnexa as well as nearby adjacent skin. Scars are largely devoid of adnexa, so it is not healing. We don't have the advantage. So you don't want to denude large areas of skin because we're healing from the periphery of that wound. So I will not often use the active FX in a standard pattern like that. We have non-ablative fractional, which doesn't have ablation. We have moderate absorption of water. We are just coagulating. And again, the pulse energy, the depth is proportional to pulse energy. You can see at the high settings, we can get it down to about 1 millimeter. But I want to point out something here. Look at the coagulation width. So from transition from a low pulse energy to a high pulse energy, we're almost doubling the diameter of the beam. So you need to be aware when you're thinking about density and dialing in your depth. Safe treatment's going to be preserve as much normal skin as possible. So you want to be cognizant of the depth and density. So these are the ways I most often use the macro fractional, the millimeter size ablation. That is using, I and others like Jill Wabel will call a painting technique, reducing the density. So put a large spot, high repetition rate, and just paint the area. We're not matching the beams, the squares, or the hexagons together. We're just painting the area. And I believe this gives some randomization and some blending of the pigmentation in the area. Or you can turn the computer pattern generator off and just whittle down the ridges and corrugations that you often see, for example, junctions of split thickness skin grafts and other areas. So I wanted to present an example here. And this is a patient that we can help a great deal in the clinic. This is a woman in her 20s and 4 months after a thermal burn. So I also want to point out the 4 months here. So surgical dogma pre-laser would suggest that we should wait a year or more before we start to revise these types of scars. The laser allows us to intervene earlier before the contractures set in, before disfigurement and disability set in. And as Andrew's going to talk about later, this is particularly important when we have children and dealing with growth. So the plan here is not just function. This is a cosmetic area in a female, so we want form and function. And the microfractional deep effects is going to be the heavy lifting for the function, range of motion. And we're going to use those newly ablated channels to deliver a corticosteroid. And then we're going to use the macrofractional to whittle down those ridges. And you can see just a single treatment with the microfractional pretty much gives her normal range of motion. Here I've juxtaposed the macrofractional and the microfractional together. You see little gray dots in the bottom left corner. That is the microfractional. And I have macrofractional whittling away those ridges. You don't want to have large areas of denuded skin in between. And a pro tip when I'm adding these together, layering these, I will often squirt a little lidocaine solution on after the deep effects, and it gives me a little extra pain control for the active. So after just a couple of combination treatments, we get a very nice result. I find it endlessly fascinating that we can turn off the inflammation by reburning this scar. So we take the after photo on the right, and then you can continue treatments, let's say with a non-ablative fractional, and get even more improvement. I wanted to mention these experimental CPT codes, which are valid in the United States. So some of you may know about 0479T and 0480T. So they are for specifically the fractional ablative laser fenestration for functional improvement. Fewer of you probably know about the ablative laser treatment for open wounds, 0491T, and 0492T. These are allocated in 5-year increments, and these were approved in 2018. So we have 3 years, and with broad use, they may be approved for Category 1 reimbursable codes, and it is better for lots of people to use it a little than a few people to use it a lot. So I just wanted to encourage their use so that we can bring this treatment to more people. So I have a couple slides of take-home points. So fractional lasers are our first-line treatment for traumatic scars, and they should be a standard of care worldwide. Patients without access may not be receiving the best available care. So the fractional lasers can treat multiple aspects of the scar, from the mobility, the pliability, texture, color, erythema. We may use all these modalities in a single patient. Use those CPT codes, as I mentioned. And you need to counsel the patient. It's going to be multiple treatments. So we tend to find the best functional treatments in about 3 to 5, functional improvement in about 3 to 5 treatments. I mentioned the high energy, low density for hypertrophic traumatic scars. And I'm sure you're going to hear that again from the other speakers. I will often combine macro and micro fractional treatments for maximum benefit in the same patient. And for skin of color, it is wise to moderate the fluence and density by approximately 30% or so, in addition to corticosteroids and other bleaching creams and things like that. So.
All right.
Shall we
All right. So I think I am now live. Can you hear me there, Pete?
Yeah, we got you, buddy.
All right. Very good. All right. Well, I'm going to start from the beginning here. And I wanted to thank everyone for joining us this evening. Myself, Dr. Schumacher, Dr. Donelon, Uber, Krakowski, and Bachowski are really pleased to bring this to you. And I kind of wanted to start out the entire perspective to give us perspective. Sergeant Noah Galloway has been on a number of different TV shows, and a lot of people kind of know who he is. But he gave an interview, and it really brought perspective of why this is important. And when he went and he was out there on doing his duty, he woke up 6 days later in the hospital unaware of what happened to him. His 2 limbs were gone, his injuries to his right leg, his hand, his jaw was shattered, and his mouth was wired shut. And during the interview, he was talking about how, everyone always told him, as far as in the military, you either, die in war, which he was fine with, or you can be an old man and go to the VFW hall and talk about what you used to do. But he was not prepared. He said, I was prepared to die, but I wasn't prepared for the in-between. And, as you've been hearing from Dr. Schumacher, that we certainly have a lot of options out there, whether it be the traumatic scars that Sergeant Gall had, burn scars, motor vehicle accidents, domestic abuse, surgical scars, or even, unfortunately, nowadays, self-induced scars with cutting. There's a lot of things that we can now do with scars. So I wanted to kind of bring in light. Dr. Schumacher is currently working both in private practice as well as the VA, but retired Navy captain and co-editor, along with Dr. Krakowski, of the SCAR book. You'll be soon hearing from Dr. Donelon as well. He's the emeritus chief of staff at the Boston Shrine Hospital. He's been a burn surgeon that's been interested and loves burn scars and scars for his entire career. Dr. Uberauer is currently a Mohs surgeon in San Diego and been involved with scar treatments with lasers for over 20 years. And Dr. Krakowski is now the program director and chief of the St. Luke's program in Bethlehem, Pennsylvania. And Dr. Bachowski is our lone still active duty gentleman who's Air Force and pretty much runs one of the more complex and integral outpatient laser centers there in the Department of Defense. And that's who we have as your panel today. As far as funding, I wanted to kind of reiterate the fact that, some of us may have gotten some funding from the Department of Defense. We're working for the VA as well as the U.S. Air Force. I personally had Luminous and Candela provide me some funding for educational aspects, but I wanted to reemphasize that no one has been reimbursed for this particular educational thing today. We wanted to do this because we were supposed to do this as a group at one of the conferences that has been canceled due to COVID, and we really wanted to thank Luminous in particular for helping us organize this and putting this information out there for everyone. So as far as I wanted to kind of give you a big picture of what scar remodeling and the scar rehabilitation is all about, is essentially taking kind of what Dr. Schumacher was talking about with some of the laser surgery, but also integrating that with some pharmacotherapy as well as some minor tissue conserving surgery, which Dr. Donlin is going to allude to as well. And so if you look about, essentially you're aerating the lung, right? You're putting a lot of micro beams into the skin to kind of help regenerate, to make this healthier. And we know now that this certainly exists and is part of the whole system. Now you can have ablative, you can do non-ablative in the fractionation aspect of things, but you also got to take into consider the vascular lasers as well as pigmented lasers, especially when you're dealing with the form aspect of a scar. So there's many different aspects to a scar and many different laser procedures that you can do in sequence or all at the same time. Pharmacotherapy, whether it be topical, whether you put it on there with or without holes, if you think about it, if you've put even a non-ablative laser on there, you're creating microscopic damage in there. And so even a triamcinolone ointment is going to be able to penetrate more effectively through that stratum corneum and through that epidermis than it did before. You can also use injectables, both whether it be applied topically, as Dr. Schumacher was alluding to, or you can actually inject them as well. Primarily intralesional Kenalog and 5-fluorouracil are the mainstays right now. However, I know that as time goes on, this is going to continue to expand as far as different types of pharmacotherapy we can inject, but also think about the systemic. We're dealing with psoriasis systemics. We're dealing with atopic dermatitis and systemics. And some of them, in particular, Dupixent may be something that we can look at in the future as far as a systemic agent that can also help us with our keloids and some of our larger scars. So I wanted to kind of really emphasize the aspect of pharmacotherapy, and then also the minor tissue conserving surgery. And what that means is Z-plasties, some of the minor procedures that Dr. Donlin is going to talk about. And the key is all three of these things, many different types of lasers, many different types of pharmacotherapy and surgeries, the outcomes are going to exceed the sum of the individual parts. We're using the patient's own natural skin in order to accentuate and make it healthier. We're rehabilitating, remodeling it, really truly making it better from the inside out. And what that's going to do is decrease comorbidity. Harvest sites, split thickness skin grafts, hopefully will become less necessary as time goes on. Dr. Donlin has this great phrase that I love talking about: the hypertrophic and contracted disfiguring scars represent the patient's most valuable reconstructive anatomy. You don't need to do these huge flaps. We know that we can rehabilitate it based upon some of the, going back even to 2012, where we know that we're changing things truly at a microscopic level. And David Ozog has this great analogy to just kind of mentally put this in our head, where normally our skin likes to be the Monet garden. But yet with some of these scars, it's like these big steel beams, and they're very hard to move around. And so those are very important to kind of understand. We're actually truly making things better. How this looks via ultrasound: you have normal, healthy skin on the left, a thin scar in the middle, and a thick scar on the right. What we can do is, after one treatment, again, just as a point of reference, normal skin with a treatment, pre-treatment area, as well as one deep fractionated laser, and you can see the amount of feedback improvement that you get with just one treatment. So what we're doing is we want to attack the form and function, as Dr. Schumacher was alluding to. And I love this just to kind of, because the why is just as important as the how. Why do we need to do this? Certainly appearance is a big, big part of it, but the psychology of that appearance is just as more important, especially when you're dealing with domestic abuse. patients being cut up or being beaten up, that scar is a reminder every single day of what happened, and it can really impact their day-to-day activities. And it can be this most minor scar, and you don't even think about it, but it really makes them perseverate on it, and it's hard for them to focus on anything else. But if you have a wounded warrior, they may want that scar because it reminds them of their buddy that they may have lost in battle. So that's the form. The why there is very critical to understand why you need to go about it and what you need to concentrate on. Is it the redness? Is it the elevation? What is it about the scar that in particular you need to address? But also don't forget about the function, the range of motion, in particular the itch, the infection. What I mean by infection is if you have a scar overgrowing hair and that hair can't get out, it's going to create more inflammation, which is going to increase the risk for MRSA infections, etc. But don't forget about the sweat and the hair as well. So that's kind of I wanted to give you a big picture. You've heard from Dr. Schumacher. Now I think it's time to hear from our wonderful surgical colleague, Dr. Donlin, who really needs no introduction. But I would really like to push this slide to you. Dr. Donlin, the floor is yours.
Thank you very much, Chad. Can everyone hear me?
Yes, we can. Well, why don't we go ahead and go to our next speaker. Dr. Uberauer, are you on the line?
I am here.
All right, so let's go ahead and until we get Dr. Donlin fixed up, we're going to kind of go to you. And let me see here. We're going to
Andrew, can you just raise your arms up slowly on both sides? Just go right up. Yeah, a little faster. Move right up.
All right. So, Nate, I'll go ahead and let you take it from here.
Okay, thanks a lot, Chad. I appreciate it, and thank you, Luminous, for making this happen. It's great to be a part of this. Something that's been very exciting for me for now over 11 years has been the use of these high-energy, low-density ablative fractional lasers for scars. It's something that should be used on just about any restrictive scar, but we're moving now to look at the early interventions that we can do with this type of technology, and realizing that we can actually change the trajectory of how a scar is going to end up looking. We can do that with many different modalities, but this is certainly another modality that can really help in changing the way a scar matures. So both scar prevention, we're preventing a certain amount of scar, and we're also creating a new regeneration of more normal tissue. And then in addition, we're able to actually treat wounds. So before they scar, and allowing them to heal with a different type of healing speed and quality. We know that if you treat with the high energy, low density, we're going to get improved range of motion in these restrictive scars. And when we treat early, we see that. A lot of times we see that before the patient even leaves the room, as in this case. But a lot of times it always takes months for scars to mature. And so the scar is going to change. And so during that time, being able to treat it safely and to affect the way the scar actually heals is what we should be doing. So how early can we treat? Well, in a blast injury like this, it's obviously a little bit too early. Why? The goal here is to prevent tension. Dr. Shoemaker mentioned this earlier with our goals. we're improving the way a scar, the tension on scars. We're preventing tension. We're also stimulating a normal collagen regeneration. So this is a bit too early, but as soon as the cosmetic reconstruction is complete, which is usually around suture removal, we can start addressing these scars. And usually that happens at about 2 weeks in most cases. But again, at that time, we want to make sure we're using low density settings. If you're using these low density settings, you're able to do it confidently and not get in the way of the scar healing, which is, again, going to take over 9 months at least for a scar to heal. So you can continue to treat from an early point all the way through the scar's maturation process and take the scar to a different point that it would have otherwise been, both in terms of restriction as well as cosmesis. But the focus is, in terms of early treatment, is allowing the scar not to have the same tension that it otherwise would have had. And so how can you do that? We do this with this awesome, I have to use stimulation package because that's what we're hearing. It's the only other statement we've heard more of than, or just barely less than COVID. But anyway, our stimulation package with the CO2 is this unique injury that it creates, a very uniformed ablative channel with a very uniform amount of collateral thermal damage. And when you use this properly and use it with low density, you end up getting, as Dr. Ozog has shown, and Chad just showed this previously, that change of a scar-looking collagen to a more normal collagen. And that then translates into better or less tension on the skin, better pliability, and often better aesthetic as well. So in terms of early treatment of scars, traumatic scars, burn scars, first of all, don't interfere with the initial heavy lifting, as Dr. Shoemaker often states, the heavy lifting of the plastics of the burn surgeons, whether it's grafting or other surgical treatments. Wait until those are done, and then, as soon as you can, start this treatment. Again, we're talking about a very, very, very specific treatment, a low-density treatment. So that's that's the first thing you want to be remembering when you're about to treat. You're not just lasing and trying to improve the scar with vascular lasers or other techniques or resurfacing. No, we're doing a very specific thing, low density. And then number 2, low density. And again, low density. Why do I say that? Because I've seen so many people try with higher densities, especially in the early treatment, and then get into trouble. Now, I'm sure there's times when that is beneficial to vary from these settings. But if you're starting out, if you're wanting to do the safest thing, this is a very safe and effective way to start early, as I did on this young patient. You can see here, after a burn injury, a mass burn injury in China. And he had already had all of the surgery he could have, but this was still a relatively new, under a month old from the burn injury, still very red. But already starting to get very tight, already starting to get the hypertrophic and tenseness to the scar. And we were able to start early and treat with these very high energy, low density settings. This is one of the first patients that Dr. Shoemaker and I treated. He's under 3 months from the time he was discharged from the hospital from a fairly significant burn involving skin grafts, split thickness skin grafts. Again, we're waiting until he's out of the hospital. we have him. It's early. No burn surgeon ever wants you to, or very few want you to start doing anything to their patient at this stage. But this is a very safe treatment and very effective in changing the way this scar matures. And what we did is on the left is the picture of him just coming out of the hospital. His arm was already tight, could not lift his arm up. We started treating him with the high energy, low density ablative fractional CO2, the Deep FX, and he immediately started seeing improvements in his range of motion. We continued to treat him. I know we followed him for at least 9 months of laser at various intervals, maybe every 2 months or so on average. And we continued to encourage that scar towards pliability by using the stimulation package of the CO2. So what are those settings? Everybody's asking for settings. The key setting to remember is the low density. And when I say low density with the Deep FX, I'm talking about 3 to 5%. You can certainly, in some with some settings, you can go into 1%. But typically, I have still never run into any problems. I've never caused a problem with a setting at 3 to 5%. Okay, and there again are times when you want to vary from those settings, from those percentages. But for the most part, if you can stay at that point, you can really treat very early and have the confidence that you're not going to re-injure the wound. The fluences that I usually start with are fairly low at this point in what we're often treating with hypertrophic scars, 30 to 50 millijoules. Some of the energies that Jill Weibel and Pete Shoemaker and myself and Chad started with, a decade ago. But those settings I find are good enough at that early stage. And I've tried all the way up to 100 millijoules on these early scars. But I think that this is enough of an improvement. It's an obvious improvement. So why try and risk any injury, especially early on, 2 weeks after an injury, a month after a burn, things like that. The pulse width and spot size I put there just to specifically say, because this is the Deep FX. It's less than a millisecond pulse width. And the spot size is in the 120 micron. I think that might be, I may have written that wrong. I think it's in the 120 micron range, but less than 400 microns. This seems to make sense, and that's a whole nother lecture on its own. Seems to make sense as why this is such a great, unique treatment that causes this regeneration or stimulation of new collagen that's going to give you a more normal collagen that will function better than what the scar would be doing by laying it down on its own. Along those lines, I just want to talk about wound rejuvenation as well. We noticed early on that as we were treating these scars, some of the chronic tension ulcers that we would see within burn scars or graft scars, or very restrictive scars over joints, we'd often see these tension ulcers, and these ulcers would melt away as we would treat and rehabilitate the scar around it with high energy, low density ablative CO2 laser. That was very interesting. We started then actually even treating right in the middle of the ulcer and found that these even worked better. I'm just going to quickly check because I see that somebody's chatting with me, but I want to make sure I'm not doing something wrong. Okay, everything looks good. Talking about chronic tension ulcers and how they improve with the treatment of the scar around them. And you ask Dr. Donnellan, he'll tell you that they've seen the same thing when you readjust the tension on a scar with a Z-plasty or with other surgical techniques. You can actually have these ulcers improve. So we thought this was very interesting that treating the scar around it would improve the ulcer. Well, what about just treating the ulcer itself? And we went to this next level. I do a lot of cancer surgery, and this patient needed an interpolation flap, but she was adamant against any further treatment. I said, well, let's go ahead and give it a try. If you look at some of Zitelli's work and others from years ago, they talk about secondary intention all over the face, that you can have improvements. Well, this was a very, very good improvement, I thought, by using the ablative fractional laser, CO2 laser, with high energy, low density, right over the wound bed 1 week after the surgery. We were able to then allow that scar to heal, to fill in, and with very, very little notching of the alar rim, and an extremely satisfied patient who didn't have to have any further surgery for a large defect that would otherwise require a very significant closure. That was very interesting to us. This is you're talking about extremely early treatment of scars, even before the scar starts, treating over the wound bed and seeing a wound bed heal better, and treating the rim of the wound bed, and allowing guiding the scar as it scars to be more pliable and to heal more aesthetically. And finally, I just want to talk about the combined scar and early wound rejuvenation. If you take all of this together, as in this patient, one of my good friends were writing a book there in China, Dr. Tan Jun. We took this patient and we're able to fillet open the scar, debulk it, but then immediately during surgery, lays with the CO2. I've done this a number of times now, and it seems to make a difference in terms of how the scar finally heals. And we can certainly show you plenty of examples of where patients with otherwise extremely difficult scars have had very nice improvements, something that you can't simply do by lasing the top of a keloid scar, but filleting it open, lasing inside, followed by Z-plasties, doing it all together, and all with the focus and goal of rejuvenating the scar and reducing tension, and doing it safely, doing it again, high energy, but low density, ablative fractional CO2 Deep FX. In summary, here's my settings again. Start with these, 3 to 5%, 30 to 50 millijoules. Great place to start. At some point, you'll need to go higher in your energies, but staying at those low densities will keep you out of trouble. And when you're an expert, you can start exploring other settings as well. But I've been doing this 12 years. I just recently treated another scar, again, with these exact settings. So it's not something that is that gets obsolete. And that's it. Thank you very much. Thanks, Chad, for running this.
All right, so now we're going to go to Dr. Donnellan. Dr. Donnellan, I believe, is on the line.
I am. Can you hear me?
Yes, sir, we can. Looking forward to it.
Thank goodness. Well, I'm looking forward to be heard. And I would like to thank all of the presenters and all of the attendees who are on this webinar for participating. What I'd like to do is to share a surgical perspective on the current state of scar rehabilitation. Let me just hit this button here. There we go. No conflicts of interest. So for over 200 years, surgeons have been making burn patients and burn scars better by performing local tissue releases and revisions. I love Dr. Ubelor's concentration on first do no harm. And this is something that's going to be part of the lesson that I'm going to try to give when I give this little presentation. Great progress was made by working with the scar tissue during the 19th century, even before anesthesia was available. As a result of this experience, surgeons emphasized the importance of preserving scar tissue. And in 1898, Dr. Stuart McCurney was able to say with confidence, in dealing with the treatment of cicatrixes resulting from burns, the prime object is to preserve tissue. In no instance should any portion of the cicatricial band be removed. Amazing thought when you think about it today. And this thinking continued into the 20th century. John Stage Davis, the father of American plastic surgery, wrote this great paper in 1931 in which he said, when we're fixing scar contractures, the scar should not be removed, but the flaps, which are composed of scar or scar-infiltrated tissue, is the way that will break the contracture. Amazing thinking. And why is that? The reason is because of the ways that burn injuries heal, as demonstrated by this deep second-degree burn of the face. Burns like this heal with epithelialization and contraction, leading to contractures, distortion of mobile structures, compression of soft tissues with hypertrophic scarring, and tissue deficiency, but dermis is still present in the vast majority of burn scar cases. In 1918, thinking changed. Sir Harold Gillies reported this Army soldier who had facial burns. He excised the scars, including, by the way, if you look carefully, all of the normal tissue that was in between them, and replaced that scar tissue with a tube pedicle flap of abdominal skin transferred by attaching it to the patient's wrist, a surgical breakthrough. And it implied that scar excision and replacement with uninjured tissue would give a superior result. Surgeons today still relentlessly pursue that premise, even 100 years later. But many burn scar excisions result in grotesque alterations of appearance. These 5 patients were all treated in major plastic surgery centers in the United States and around the world. All have had more than 20 reconstructive operations, and this is the result, grotesque distortion of their appearance. And these old ideas die slowly, even when proven false. This paper was published just recently in a plastic surgery journal showing a minor facial burn injury treated by excision in this incredibly complicated morbid reconstruction, and it was actually published in a peer-reviewed journal. You can get a good feeling for the negatives of burn scar excision by looking at what we call type 1 burn injuries to the face. These are patients with normal faces but happen to have hypertrophic scarring after a burn. The top 3 of these patients have completely normal faces. The bottom 3 actually have some contractures associated with their hypertrophic scars, but in general they're normal faces. The upper 3 were treated with scar excision and flaps. The bottom 3 were treated with lasers and scar revision. The outcomes are strikingly different. The upper 3 all have grotesque deformities after extensive surgery. The bottom 3 all look completely normal after their laser treatment and 19th century scar revision interventions. So now we can say that lasers and scar rehabilitation enable us to use the patient's healed scars as their reconstructive tissue. No scars were ever excised from this young man's face. How has this happened? We all know that Tina Alster started this when she published a paper in 1994 demonstrating that the pulse dye laser was effective in treating erythematous and hypertrophic burn scars. But her results were largely ignored by both plastic and burn care surgeons. But it turned out that using the pulse dye laser in combination with the synergistic effects of tension relief, as was just recently mentioned, by rearranging the local tissue, resulted in significant benefits to even major facial burn scars. At the time of this paper being published in 2008, it was fair to say that excision should rarely be used in the future for the treatment of hypertrophic facial burn scars. This was heresy after Harold Gillies' work, but it's become even more obvious that that is true with the development of fractional ablative CO2 lasers, which have demonstrated more power in dealing with scars than the pulse dye laser was. So I think it's fair to say that scars rehabilitated by plastic surgery and lasers are now superior to excision and replacement in both aesthetics and function, which we've been talking about. They appear normal, although they're not perfect. They blend. They're not grotesque. And by using the patient's own scar tissue, it essentially eliminates donor site morbidity. And the function is superior to flaps and grafts in virtually all cases. If we look at this young man who was treated with lasers and tissue rearrangement, and then look at the video, you will see that his function is essentially normal because the dermis is preserved. As I mentioned, old ideas die slowly. This article was recently published in the New England Journal of Medicine, a review article on the management of burns, and the word laser was not mentioned in the text or the bibliography. Closed minds clearly need to be opened. But what our job is to do is to recognize that these hypertrophic scars can be their most valuable asset for their reconstruction. And it's our responsibility through accurate scar analysis, conservative management, and the effective use of available emerging technologies to enable patients to reap the maximum benefit from their own amazing wound healing capabilities. Thank you very much.
Thank you so much, Dr. Donlan. That's so true, and I appreciate your insight and looking back at the history. Look forward to actually hearing from Dr. Krakowski now, one of my favorites to listen to as well. Andrew?
Hey, thanks for having me, guys. To have been included. Focus as a pediatric dermatologist is on children, and specifically the function aspect of what we can do for these scars. What got me interested is just the sad, unfortunate truth that there's so many scars out there, and if you believe the statistics, most, if not the vast majority of them, are being acquired in a pediatric population, and you can argue that's iatrogenic now with surgeries, but you can also imagine that trauma plays a huge role. And for me, my interest in pediatric dermatology drew me to, when I was back in San Diego, drew me over to the Navy's Balboa Medical Center, where I had the good fortune to meet Dr. Shoemaker and Dr. Jubelhauer when I was a trainee. And I was drawn to this concept that a laser could soften a scar. And to me, a softened scar is a more pliable scar, and a more pliable scar means hopefully or potentially less loss of function. And in the world of pediatrics, we know that function is everything. There's this true phenomenon of use it or lose it. And when it comes down to, for this audience, if you're watching this because you already own the Luminous UltraPulse or you're thinking about getting it, if you own it, you should be doing this, because even 1, 2, or 3 treatments can truly change a kid's life and give back some function that's lost. If you don't own one of these lasers, you could be doing this pretty easily. And I'll tell you, the barrier for me was simply just jumping in and doing it. You just had a wonderful talk from Dr. Jubelhauer. You stick to the held sort of paradigm, high energy, low density, you're not going to hurt anything. And I guarantee you will make this better. So for me, I was drawn to the idea that kids with these scars that were otherwise function limiting, there might be some ray of hope. And in fact, the more I got into this, the more that you find out that there's in fact this thing that's sort of referred to as the survivor's paradox. The idea that, from Dr. Donlan's slides, kids were not supposed to survive some of these horrific injuries that they've had. And now, guess what? Amazingly, modern science is keeping them alive and bringing them to the other side of bright. But when they survive, they're being asked now to deal with new sequelae that they could never have imagined. Dr. Hivner's, I was prepared to die except for the middle part, right? Physically, psychologically, socially, and I think very importantly, financially, we're asking our patients to survive their injuries, and I mean survive both figuratively and literally. And that to me is fascinating and a dilemma, quite honestly, that we have to deal with. I think in addition to those bigger buckets around a scar, there's also a tendency for us to forget that some scars can truly be pathologic. And it really does behoove us to take the time to ask our patients. Many scars can itch, they can hurt, they can stay red. Many scars can, in fact, sort of be involved in chronic wounds. You heard from Dr. Jubelhauer how the lasers can be used to treat the chronic wounds. This is an example of a child who had an abdominal excision, and you can see those tension lines on his little tiny belly that they're putting so much pressure on, you can't see past the G-tube there at about the 11 o'clock position. There's an open wound that's being held open by all the tension going through that little child's scar. And then I would also argue, maybe maybe more so in kids, there's a psychosocial discord between the reality of what I see the scar to be and what they perceive the scar to be. This is a child, you can barely see this imperceptible scar down at the lower cheek. It was a dog bite. And this child came to me for help, or I should say his mom came to me for help. And I looked at this kid's scar and I said, the only thing that I would do is not let me within 20 feet of this scar, because there's nothing I could do that nature hadn't done already way better. And I left the room thinking I had done a service for my patient. The mom literally chased me down the hallway and said, no, you don't understand. My daughter, she's losing friendship. She's changing as a student. She's doing worse in school. Her entire world has changed as a result of this, what I would consider an imperceptible dog bite scar. And the point here is there's a true discord that can exist. It's underappreciated, often underreported, and truly both by family members and society, sometimes under-acknowledged. How do you get to be like that young girl and be so psychosocially driven by what I would argue is physically a small scar? Well, I don't think, this is where I get up on my soapbox, I don't think that we as a society have done a lot to prep and support our patients for that whole survivor's paradox. I think if you look around and take some cues for what we are trying to sort of subconsciously teach our patients, we're not doing the best job at setting them up for success. And I think the three best examples you can see in modern media here. So the first one is a horrible villain that we might know and recognize as Scarface, played by Pacino. You know, literally he's got the name Scarface in there. He's one of Miami's most notorious drug dealers. Okay, that's an adult role model. How about a kid's role model that maybe we're sending the wrong message with? Well, you've got the most famous Z-plasty in all of the universe. This is a sign that Voldemort, killed your parents. Great. That's something that I want to remember every day I look in the mirror, to Dr. Hivner's point about living and reliving the experience on a day-to-day basis. And my personal favorite, I'd like to thank Disney for this one. Certainly not supported financially by Disney here. And I'd like to just throw out my favorite one. You know, if you're going to name the guy who kills the Lion King's dad anything, why not name him Scar? You know, and I always think it's funny, but it's sad. If you named this lion Diabetes, what would the public's uproar be? You know, are you kidding me? You named him after a chronic medical condition that a kid has to live with for the rest of their life? Well, you did. You named him Scar, and it drives me crazy. And I think we as a society can do a lot better than what we're doing. But it starts with asking the questions. It starts with listening to the patients and hearing how their scars are affecting them. The focus of this talk is how scars can also limit function. And this was really one of the first patients that I started treating on my own at Children's Hospital. This was a child that was involved in a motor vehicle collision. And if you look down at your own feet, I'm not sure if you're all at home now with trying to outlive COVID here, but if you're not wearing socks or pants, look down at your foot. You should not have a thick, broad band. It's not a tendon that's going through this child's foot. This is a deep dermal injury that has left a thick cord going right through the lateral aspect, or actually medial aspect of his foot. You can see the areas of hypopigmentation and hyperpigmentation. That's the modeling that can occur. And this child's functional deficit was, if he was a little older, let's say plantar flexion. We're trying to push the accelerator down on the car, and he was unable to do it. So really, as one of my first patients that I was treating on my own, I started to focus on the area that was, for him, the most painful and most nodular, that the middle portion of the scar there. And I hope you can start to see that with several laser treatments, again, high energy, low density. I never went over 50 millijoules. I never went over 5% density with him because I was too scared, having just started doing this. And you can see that the skin, the laxity of the skin over that area starts to increase. And I hope that you can appreciate, as time goes by, that the area that I was treating in the middle is much less nodular compared to the superior and inferior portions of that same scar. And that to me was really sort of the first time I could physically appreciate that the laser was doing something more than making me feel good about myself and maybe placebo effect for my patients. The next opportunity came in this young child who, unfortunately for him, was born with fused first, second, and third toes on his left foot. And the orthopedic surgeons decided that they were going to try to increase, and I should say restore, his ambulation ability by separating the first toe from the second. They kept the second and third fused for stability purposes. And the surgery itself went great. It was in the healing process and in the rehab process where the child started to try to learn to walk again that he was developing these thick keloid type scars in between the toes. And you can imagine it would be like having two cashew nuts between your toes, and you're trying to learn how to not only walk and run, but walk and run correctly, as you haven't been able to balance, quote unquote, properly since birth. And this child was having none of it. He couldn't do it. So they asked us, what could we do to help improve the scar? You'll see in the side here, B, we focused really on three deliveries of therapy. The first was we used Pete Shoemaker, as he described, macroablation to really hammer the thick portions of the scar down with the luminous laser and flatten them out. Then we used the UltraPulse, the Deep FX, to drill tiny little holes in the tissue, both right at the point where it was most impacted, but also in the periphery. And again, never went over 50 millijoules, never went over 5% density. Out at the periphery, it's more around 25 to 30 millijoules and 3 to 5% density. And then we followed that with laser-assisted delivery, which I know we're going to get back to at the end here. That's very simply when we deliver corticosteroid in the form of triamcinolone acetonide in solution to the microablated channels and let sort of the pooling effect channel down and bring the medicine into the skin. And with those couple treatments, we were able to totally flatten out those scars. This kid, I promise you, could run around the OR better than anyone in that hospital by the time this was finished. And the scars amazingly never came back. And if they did, it would be okay. It's not a defeat. You just retreat them. It's great. So that really did it for me. And I'm going to share with you a series of patients here, 1, 2, 3, and 4, that I hope drive home the point that anybody can do this. This is not something that you need to spend 5, 10 years learning how to do. You might need to spend that much time to get really, really good at it, but to make an impactful moment in a patient's life does not require years of training. It requires some good knowledge base and some humility, and you will be able to do this on your own. I would also like to point out that all 4 of these patients, the punchline here is that they had plateaued in their physical therapy, occupational therapy, meaning they had their scar. We'll go through their clinical cases, but the point is they had been receiving PT/OT and had been unable to improve their function from traditional conventional PT/OT alone. And this first patient is one of my favorites. He's an 18-year-old now. When he came to see us, he as a 3-year-old grabbed a hot iron, so his scar is 15 years old. That's not a recent event. So 15-year-old scar, reached up, burned his hand. You might have heard of the term white knuckling, where you grab something so hard that your knuckles turn white. He's actually, I guess, white palming. He's trying to open his hands, and you can see those areas of vasoconstriction. He's trying to open up against the resistance of his contractures. And if you asked him what he wants to get out of the therapy, he says, I just want to be able to open a jar of peanut butter without my mom knowing I'm raiding the cupboard. That's it. As simple as that. Okay, so I'll set him up. The second patient is another example of that deep sort of dermal cord injury that I mentioned with the motor vehicle collision patient earlier. This is an 8-year-old who, as a child, about 1.5 years of age, had climbed into a porcelain tub full of scalding hot water and chemical chlorine bleach. She had the wherewithal, sort of like a cat, to get in her body and her face out of the water. Her wrists and ankles took the brunt of the damage, and these deep thermal injuries left basically cords of rope running through her dermis and beyond, actually. And that's not me twisting her hand. That is literally what her hand looked like. So also note that her scar was 6.5 years of age. Patient 3 is a younger child, had what unfortunately has become sort of a common occurrence, in patients I see, treadmill accidents. She had got her arm caught in a treadmill and had developed this very thick, it was 4 millimeters thick, the scar itself. And now as she had blossomed into this young woman, she had picked up the violin and was actually quite good at it. But when she's supinated, which I believe from anatomy is you're holding the soup, right? That's supination. So she's supinating the violin, and she's feeling a pulling and a sort of a prickly sensation running through that area of her arm. And it was really affecting her ability to play. Patient 4 is probably my favorite patient. Unfortunately, another treadmill injury, 2-year-old who had become or started to become right-handed. Okay, and that's a very important milestone in the world of pediatrics. You don't mess with handedness. If the kid's going to be a left-handed pitcher, you don't try to force him or her to be a left-handed pitcher, and vice versa. This child was showing right-handed dominance until she got her hand caught in a treadmill accident and degloved her 3rd and 4th finger. Plastic surgery, to use Pete Shoemaker's expression, did the heavy lifting. They grafted her and put some skin back onto her little fingers. Unfortunately, the graft does what it does, and it contracted. And we're using an instrument here that's supposed to try to illustrate to you the inability of her to her decreased range of motion. And when you talk about range of motion, there's really 2 aspects to the range of motion. There's active motion, which is what the patient can do himself or herself, and in this case, there was almost none. Then there's passive range of motion, where a third party, in this case, this is actually Larry Eichenfield's fingers. I'm taking the picture. He's trying to open her finger, and he can't do it more than what you can see here on this graphic. And it should be at least 180 degrees. There's about a 10 to 12 degree difference that this child is unable to overcome. Okay, and I hope you can see this, but all 4 patients were treated, not 10, not 20 times, not even 5 times. 1, 2, 2, 1. Those are the number of treatments that we were able to do on these children and see tangible, objective results. The parameters are here for you to use. They've been published. Some high densities, but basically in the area of what Dr. Eberhauer has said. And all of these patients, except for the 2-year-old who was too young to tell us subjectively if everything was better, but the 3 old enough to, all subjectively stated that there was an improvement. And most importantly, and that's most importantly for the patient, I believe, most importantly for me as the treating physician, and yes, most importantly for the insurance company who doesn't want to pay for these services, we have established that there's objective improvement. And the child who wanted to grab the peanut butter jar, able to do so. The violinist playing, she was actually able to supinate more than her unaffected arm. Believe it or not. Okay, and the 2-year-old went back to being right-handed. So that's the punchline there. But let me key in a little bit on this use it or lose it phenomenon I mentioned. Here's the gentleman who grabbed the iron. So you'll see, this is not just a fly-by-night sort of thing. He'd been working at physical therapy from, November 2010 to November 2012. 2 years of physical therapy, occupational therapy, trying to improve the function in his hand. And it's a flat bar. It's dead wood. It's not getting any better. That dotted line vertically is the use of the laser. We interceded with the use of the laser at that point. And you will see immediately his 5th digit, first digit opened up. That was his ability to open his hand. And it improved, and it stayed improved. Very similarly, but in a little bit more complex of a graphic, you will see that the 2-year-old who injured her hand in the treadmill also improved. For this one, the graph's a little bit more difficult to understand. Here, the y-axis is, the x-axis is at bottom, at baseline, is what she should be able to do with her hand. And I think it was Dr. Donnelly who talked about how a scar matures over time. Dr. Hibner did as well. And what you'll see is, in some ways, the scar after the injury to the y-axis there, it actually improved a little bit, but it also at different points worsened over time, such that at some point she flattens out just like the preceding patient, and she is not improving at all until that laser hits and the function gets her back to baseline. Enough so, as I pointed out, that she is now back to being right-handed. And she does need touch-up surgeries. Every now and then, she will come back to Children's Hospital and get a touch-up surgery. But the point is, this is not use it and lose it. This is a use it and improve it opportunity. And there she is graphically demonstrating that fact. Okay, she's flattened out with passive range of motion. This was also found to be true for pediatric burn scars. I won't focus too much, but this was an objectively focused clinical outcomes study that was done not in surgical scars, but specifically a burn scar population. And no surprise, since we're talking about it, it holds true as well. Now, I'm kind of coming to the end here, and I just want to make a push that I think if you're interested in this from the perspective of pediatrics in general, but then also if you're looking at this from what we can do best for our patients, then you have to start thinking about evolving towards a peds or maybe even an adult scar team, right? This was a child, a 5-year-old from Mexico who had come up to see me, ravaged by meningococcemia. I mean, necrosis of basically his entire kid's little body. He's lost digits. He's been grafted back from areas that have just literally died and rotted off of him. Almost every joint is affected by this little guy, and he's under general anesthesia seeking some help. But I would argue that at the end of the day, this is not just a pediatric dermatologist with a laser that's going to make this kid's life better. It starts with a quarterbacking pediatrician who can ask those questions if the rest of the team forgets. It continues, I should say, with an anesthesiologist who's comfortable and safe treating a kid. Infectious disease, plastic surgery, derm, even orthopedics, as this may involve bone, need to get involved. Nutrition for optimal improvement. I can't stress that enough. It's a great, if you're missing vitamins and you're nutritionally deficient, you will not heal as optimally as you can otherwise. Psychology, getting these kids in to understand that, let's start with, it's not your fault that this happened to you. Normal, okay? You can live a normal through this. And of course, PTOT. I would like to think that someone from this audience might join that SCAR team as well. And okay, so this is my last slide. And for anybody who's sitting there going, I think this sounds pretty cool. I'd like to do it, but you know what? I'm an outpatient setting. I'm not comfortable taking care of kids. I don't really know what I'm doing. This was the second patient that I ever treated. Dr. Shoemaker and Dr. Huberhauer are in the background. Set this up that this is a very tiny child, 9-month-old child, who had cardiac surgery, had a bikini, sort of what they call a bikini scar under her both breasts, and it was a hypertrophic scar. Mom asked us to help improve because it was actually very red and irritating to her. With ice alone in our outpatient setting, we took on treating this patient, and I hope the video will let you hear what's happening here. But pay attention to when the laser's being pulsed versus when she is doing her crying. Okay, here we go.
Totally quieter. I think we're going to tell this to parents for. Boy, I'm going to try this tonight in bedtime.
Unbelievable. Please extend it. Oh, yeah.
Is that it? She started crying when we were done.
So I hope you could hear that she, in fact, stopped crying when the laser was first pulsed and actually started crying when we stopped the laser procedure. So, feel, all joking aside, feel like you can do this. Get involved. It does not take much time to learn enough to make an impact in a kid's life. And if you do it just one time, I promise you it's worth its weight in gold. Thanks so much for having me.
All right. Thanks, Andrew. Now we're going to go to Tom Bichowski, kind of talk about some of the recent advances in literature searches.
Thank you, Chad. Just a few disclosures here. As Chad mentioned, I still serve on active duty in the United States Air Force. I receive active funding from the Air Force and the Defense Health Agency and NIH for research not related to this work. And you can see some of the honorary I've received below. Moving on, there is too much to cover in terms of new advances, but what we've already heard about is multimodality treatments, multi-specialty treatments. These type of comprehensive approaches tend to provide the best outcomes for our patients. But expanding beyond the concept of carbon dioxide or CO2 laser resurfacing, laser therapy can harness energy throughout the electromagnetic spectrum. And what we're seeing now with some of our newer, faster lasers, the picofractional lasers, there are case studies and case reports coming out where you're seeing various wavelengths used at these very, very fast pulse durations have a positive effect. One of the things we're seeing here is it's perhaps not the laser effect itself, it's the photoacoustic effect, it's the shock wave, it's the sound energy and the speed at which it's traveling through the tissue that's causing an injury that's leading to regeneration of that scar tissue. Moving on, there's some new research put out looking at preoperative extracorporeal shockwave therapy to help prevent scarring. So if we know that there's going to be a surgical procedure, something we can plan for, is there a way to prepare the skin in a way that it may be less susceptible to scarring? And then we've heard about this multiple times already, but laser-assisted drug delivery, that's essentially the use of a laser to create channels into the skin to deliver different medications. We've heard the most about Kenalog or triamcinolone as a topical steroid, but other medications and drugs that are used today include 5-fluorouracil, some new studies coming out with verapamil and how they may help reduce the size of the hypertrophic scars and keloids. And then as we move on a little bit towards the end of my talk, I want to briefly touch on personal protective equipment, PPE, in the COVID-19 pandemic situation and some recent guidelines that have been published. But before that, I want to focus on a few very high impact prospective and retrospective studies that I think will give a little quantitative data for our listeners out there who are wondering, where do I start? How do I get better at this? What is a potential way I can think about for adapting my settings as I move forward? We've heard some very good suggestions on settings and densities, but hopefully what you'll see over the next few slides is something to help you think about how you want to adapt those settings based off of what kind of response you're seeing in your patient population. So as an overview, these are three of the article titles that we're going to go over. At the end, I'm also going to mention a brief piece of information on a provisional care policy, the TRICARE, that's the medical insurance carrier for those within the Department of Defense that's looking at for considering the payment for these types of services off base through insurance, which isn't currently available right now. So the first study published by Jill Weibel recently, randomized control early intervention of dynamic mode fractional ablative CO2 laser on acute burn injuries to help prevent, and the key here is to prevent pathologic scarring. So some of the old dogma that we've already heard be challenged with our speakers tonight is how early can you treat a burn scar? You ask 10 different doctors, 10 different surgeons, you might get a couple different answers, but objectively, this group sought to treat scars within 3 months, as long as the skin was epithelialized, meaning it was closed, it wasn't oozing, it didn't require any bandaging. These patients were thought for enrollment. So the question is, for this study, is it safe? That was their main objective here. They enrolled 19 patients with moderate to severe acute burn injuries with both partial and full thickness burns. And they followed these patients with the Manchester Scar Scale as well as photography. And they performed 3 treatments with ablative fractional resurfacing every 8 weeks with the settings that you see below. And what you can see here in this chart is I want to draw everyone's attention to the p-value. Everything's statistically significant. So they saw improvements in color, matte versus shining, contour, distortion, texture. Everything they did seemed to get better in this patient population. So their primary outcome, not only were these treatments safe and effective, but oh my goodness, the secondary outcomes, everything got better. The collagen organization improved. They saw reductions in blood vessel diameter, improvements in epidermal thickness, the honeycombing appearance, decreases in erythema, and improvements in texture. So the take-home points from the study, things to consider, is less than 3 months appeared to be safe within this study design. And as I mentioned before, all the patients were reepithelialized prior to treatment. But how soon is too soon? And one of our speakers earlier tonight said, in his clinic, and once sutures are out and the skin is healed, it's worthwhile considering that's the time to start treatment. And I think, as we learn more, we start to push the envelope, and I think that's absolutely a reasonable consideration. But you have to take into account the patient, the injury, what else is going on within their medical history. It's not just a carte blanche. Not everyone is going to be a good candidate for that type of early intervention. Next study. So this gets to the consideration, how deep do I need to treat? We keep talking about low density, high energy, but what does that mean? And this provides a little bit of objectivity to that thought process that we all use here. Ablative fractional resurfacing with laser facilitated steroid delivery for burn scar management. Does the depth of laser penetration matter? So in this retrospective study, they treated 78 patients with 158 scars, and they divided the patient categories into 5 different groups based off the depth of laser penetration according to the deepest scar. So I'm going to say that again in the context of the different groups below. So they looked at the depth of laser ablation versus the deepest scar. So they treated scars up to 25%, between 26 and 50% depth, between 56 and 75%, between 76 and 100%, and in a very small subset of patients, they treated with energy settings thought to go beyond the depth of the scar they saw. And all treatments in their hands were followed up with laser-assisted drug delivery of triamcinolone or Kenalog. So that's essentially the application of a topical steroid after the laser procedure. And then they went on and divided these scars into 2 different groups. They said, do old scars and young scars react differently? So they defined immature scars or younger scars by being less than 2 years old. And what they saw, the biggest effect, the most improvement in this study was noted with depths of ablation thought to be 51 to 75%. At depths a little bit deeper, 76 to 100%, there was no statistical difference in findings, and anything greater than 100% was noted to be worsening. Within the mature scar category, these are scars that were greater than 2 years old. They saw their biggest effect at a little bit lower energy settings at 26 to 50%. So moving on, what other outcomes or points did they look at here? They looked at the Vancouver Scar Scale, the patient surgeon observer scales, and what they noticed is there were improvements at all laser depths up to 75%, where depths a little bit higher, again, no statistical significant improvement, and greater than 100% actually showed deterioration. So this kind of gets to the point where we're talking about before. High energy used inappropriately can actually make the situation worse. And I can speak at least from my own clinical practice, where in trying to treat some patients with scars at variable density or various thicknesses, unfortunately, sometimes this is going to happen. Scars are dynamic. If you're treating someone with expansive burns, in one area, a scar may be very, very thick and hypertrophic, and right next to it, it may be atrophic, or you may have ulceration. So you really have to be considerate on the thickness of the scars as you're moving throughout the treatment. So in this study, going back, their sub-analysis, looking at the immature scars and the various scales they used here, again, they saw significant improvement throughout all the penetration depths. With the mature scars, they only saw significant improvement up to 75% depth. Looking at a few other clinical findings, they were interested in evaluating, does pain and itch also correlate with depth of ablation? So they saw significant improvement across all penetration categories except greater than 75%, where they saw worsening of neuropathic pain. And you see similar findings with itch. So again, this is just another way to warn us that using too much energy and going too deep can cause clinical outcomes that we're trying to avoid. But this isn't a perfect study. No study is perfect, but what are some of the limitations here? They applied Kenalog in the form of laser-assisted drug delivery after each of the treatments, which, as we know clinically, has a significant effect. Otherwise, we wouldn't do it. How that affected the outcome in this study, it was not controlled for, so we can't we can't discount its potential effect on the outcome. And they also, I wrote here, they used a non-standardized clinical adaptation of laser settings. So what I mean by that is they measured the thickness of the scar in the deepest area, and then they calculated the depth of ablation based off of manufacturer settings and publications as to how deep to go. But they said, and it makes sense, we don't want to use that energy across the entire scar for the point I just made. You're going to have areas of thinner scarring, atrophic scarring, ulceration, that those high energy settings are going to potentially and likely cause problems. So they used their own clinical guidance, not published really, just to decrease the energy settings in those areas where scar tissue was thinner. So how much of effect does this play? It probably isn't going to affect the measurement or improvement at the thickest areas. However, a lot of those other subjective findings, pain, itch, they may certainly be affected with this. So the assumed depths of laser penetration, as I mentioned, these were not measured. These were just based off of energy and published data. And they didn't standardize the treatments for Fitzpatrick skin type, ethnicity, or scar maturation. So these are all very important points to consider, but studies like this are very difficult to perform prospectively. So that just leads me to the last point here as a limitation that this was a retrospective design. I think it gives us some information to think about, but it certainly, it's one study, and I think using this information moving ahead may be beneficial for those clinicians and practitioners that are performing procedures to help you get an idea. You know, if you treat a patient, if you see a side effect, if you see a bit of improvement, conceptually, how deep are you treating? It may be something to think about. Unfortunately, within our clinical practice, devices and ultrasound machines that measure depth of scarring are not widely available, nor is there application and indication for use in treatment. So I think, speaking for all of the surgeons here, if I can, how we treat and how we choose to treat, we use our fingers. This is our caliper. This is how we measure depth. Much the same way an OBGYN can tell the dilation of the cervix in a pregnant female upon delivery. This is something that's learned with time and something that I try to challenge myself with every time and try to get a good appreciation for how thick those scars are, because that's how you're going to decide how to adjust your settings. So take-home points. This was, as I mentioned, an interesting study. It brings up lots of questions. It's hard to apply this to your own clinical practice. Most of us don't measure thickness with ultrasound. But it is interesting to note that what they saw for immature scars, those younger scars, had the greatest improvement with treatment ablation between 50 and 75% depth, whereas the more mature scars tended to improve with less energy settings required. So moving on, this article, who you may recognize some of the authors here, Dr. Hibner, Dr. Donlin speaking here today. Fractional ablative laser therapy is an effective treatment for hypertrophic burn scars, a prospective study of objective and subjective outcomes. So this was published just recently in 2019. And what they looked at was a multi-center site-controlled prospective study. They enrolled 22 patients that each received 3 monthly treatment sessions with ablative fractional CO2 resurfacing. And they tried to perform objective measurements using skin torque, ultrasound for scar depth, and then reflectometry to objectively measure erythema and hyperpigmentation, which are two of the challenges with scarring that we'll hear a lot about from patients. You know, we've talked a lot today about treating the hypertrophic scars or keloid scars, but in my practice, in the military, we have a large number of patients with skin of color with some of your higher Fitzpatrick skin types, and they often develop a post-inflammatory hyperpigmentation and sometimes post-inflammatory erythema. Maybe that's more so in the lower skin types, but that can be very, very upsetting for the patients. Just as Dr. Krakowski was mentioning with his pediatric patient, the scar on her cheek, So it's important to really listen to your patients and understand what part of the scar is causing them problems, what part are they most upset with or concerned with. So moving on, the subjective measures that they evaluated in this cohort also included health-related quality of life. And this is kind of what I'm getting at. How does this scar affect them? Overall, are they getting better or getting worse? And then they used similar observer scar scales as some of the other studies, as well as blinded scoring with photography and before and after. So the point here very, very quickly is everything got better. The elasticity of the skin was better. It stretched better, recovered quicker. It was more extensible. The thickness of the skin improved. The observed appearance improved. And pain and pruritus absolutely improved. So these types of treatments, not only do they help with symptomatology, which is very, very important, we want function, but we also want form in our patients, and they'll let you know what they're most interested in. But this is a very well done, very well thought out study that provides objective data to show these results absolutely are attainable and possible, and it's not just an anecdotal improvement. So this is very encouraging and something I like to share with my SCAR patients that ask, can this really be done? And I say, you don't have to take it from me. Here's some of the published literature, people that have been doing this for years, and look at the results that they're obtaining. So I think it's confidence boosting for a lot of our patients. So take-home points, ablative fractional CO2 used every 3 months improved everything in this patient population. So definitely a tool to add to your tool belt if you're interested in this type of patient population and scars in general. And then moving on, slightly different. So I mentioned I wanted to talk about the provisional care policy that TRICARE is considering. I think this is very important to bring up because most medical insurers do not provide compensation, for these types of treatments. There are instances where this can be done, but the CPT codes that Dr. Shoemaker had mentioned before, these are temporary codes. They're currently under review. And for those of you that are currently performing these procedures right now, even though you're not reimbursed for the use of these CPT codes, it's important and imperative, I'd say, that you use them because these are being looked at. If these codes aren't used, the likelihood of consideration for reimbursement is going to be much lower. So again, if you're performing these procedures or interested in performing these procedures, please make sure you're using these codes. They're not just utilized for reimbursement, but they're also utilized in terms of trying to evaluate who's using these codes, how often they're being used, and are they worthwhile in consideration for making a permanent stay within the CPT coding guidelines. So, and then lastly, I had mentioned I wanted to just touch on a consideration of what do we do right now for PPE in terms of the COVID-19 outbreak. How do we stay safe as providers? How do we keep our office staff safe? And how do we keep our patients safe? These are fresh guidelines that have been recently published. There are more guidelines coming out. But again, these are guidelines. These are not randomized, double-blinded, controlled studies. We don't know. So in terms of trying to be safe, these are very conservative recommendations. And I would refer everyone watching to download this paper, download some of the other ones that are coming out. They provide some very useful tables that you can use to consider implementation of some of the recommendations within your own clinic. So for example, in table 1, they provide just very nice clinic cleaning and disinfection guidelines, whether it's your treatment rooms, waiting rooms, reception areas, lab, offices, bathrooms. This isn't so earth-shattering here, and a lot of this is probably already done. But if you have new office staff or you have high turnover, I find having checklists very helpful in my clinic. It helps keep the office staff organized, and it's much easier to make sure things are getting done if you can have your staff review standardized guidelines like this. In terms of OSHA occupational risk exposure, I'm just going to have everyone jump down to the bottom box here, very high exposure. High potential for exposure to known or suspected sources of COVID-19 during specific medical or laboratory procedures. This includes performing aerosol generating procedures, which in many cases have That's what we do with CO2 lasers. That's what many lasers do. So performing any laser procedures on the head, neck, or around the areas of the body that are thought to have a higher density of viral load, not only for this condition, but this makes us think a little bit wiser and more open-minded about other infectious diseases. What are we exposing ourselves to currently as laser surgeons, as providers? Are we doing what we should be doing to protect ourselves, again, our staff and our patients? So their bottom line recommendation here for those providers performing energy-based procedures on the face and the body, they recommend maximum available level of PPE, including the wear of an N95 mask or an equivalent, protective eyewear, and a face shield, gloves, gown, and surgical cap. So this is probably more extensive than what most providers in laser medicine are wearing. This isn't a law, this is a guideline, this is a recommendation, but this is something that I would encourage those laser surgeons and those that are performing these procedures to strongly consider, because we don't know what we don't know, and we want to keep everyone safe. A lot of these procedures we're performing for scars, they are important. They need to be done, but are they urgent? Are they emergent? Do they need to be done right now? Do we need to take other safety precautions to make sure that we're protecting ourselves and our patients and our staff appropriately? That's a question that probably should be answered based on the context, but things to think about, things to consider. And with that, I'm going to turn it back over to Dr. Hivner, and thank you for listening.
All right, so I think we'll take a couple of questions. If y'all have any specific questions, please feel free to go ahead and type some more in there. But I'll answer one, and I'm going to kind of have a couple that are going to go around to the rest of the folks. But one question was asked about interlesional kinolog and 5-fluorouracil in the concentrations and percentages. Well, certainly, I always use the interlesional kinolog at the concentration of 40 mg per cc, and then the 5-fluorouracil is standard at 50. It's important to note one of the questions also stemmed from, well, how much is there a limiting factor as far as 5-fluorouracil? And I actually use the limiting factor of more of the interlesional kinolog more than 5-FU. Whenever you're doing chemotherapy, 5-FU is literally given in the thousands of milligrams the first day, and so then they kind of continue to give that. And so really just 50 to 100 milligrams that we may be kind of giving is going to be very, very nominal in comparison to anything else. What I typically do is I'll put it in the same syringe, 1-to-1 concentration where you're getting ILK 20 and 5-FU 25, or if it's a thinner scar, then I'll kind of go up on the 5-fluorouracil concentration and kind of go lower on the interlesional kinolog. For those who have injected kinolog for a long time, we kind of always based upon the concentration of the kinolog based upon the size or thickness of the scar. And then same principle, but instead of using saline to dilute the kinolog, I just use the 5-fluorouracil to kind of dilute the kinolog. And that's kind of how I particularly approach that. And it kind of is a variable thing, and every patient's going to be a little bit different. If there's more resiliency of that, or if it's bouncing back, then maybe you need to go a little bit more with 5-FU, because the 5-FU stops cell replication, so it's going to kind of help prevent those scars from kind of regrowing. One question that kind of came up that I'm going to probably give to Dr. Schumacher is, one of the questions is, can you do this with keloids as well, or the deep FX and this kind of approach, or is it just with hypertrophic scars?
So yeah, the keloids are a different beast and they behave more aggressively than hypertrophic scars. So yes, I in my practice, it can be helpful. High energy, low density, especially in combination with medical therapy. So 5-FU, interlesional kinolog. There's been a couple of comparative studies, and both triamcinolone acetonide suspension and 5-FU can be helpful. Often used in combination. The ratios vary from anywhere from 2-to-1, 3-to-1 to 9-to-1. And it depends on, you want to be aware of the surface area that you're applying it over, the age of the patient. So kids are going to have more surface area to volume ratios, need to be somewhat cognizant of that. So I have found that it's helpful to lays the keloid first and then inject. Because in reality, if you look at a gel model, it's not just a 120 micron column, but there's a shock wave, and you break up those collagen bundles, and you can get more medication in using it both topically and intralesionally. So yes, but it's not a home run as often as it is with hypertrophic scars and contractures.
All right, thanks. So Dr. Uber, one question was on the ActiveFX settings. What do you typically like to use for your ActiveFX, whether you're kind of painting or just kind of sculpting things out? What settings do you like to use if you're using the active in conjunction with the DeepFX?
It all depends. Can you hear me okay, Chet?
Yes, sir. Yeah, I got you.
Again, in terms of my lecture today, I don't use the ActiveFX early on in scars, but later, in terms of etching them, I may use settings as high as even 90 millijoules with a very low density. Or like a setting of 4, or with ActiveFX, or even take off the CPG, the computed power or pattern generator, and etch the scars. But most of the time, I'm using it at much lower settings. So I'm using a very something around 30 millijoules with ActiveFX. And using a very low density but a very high rep rate. And I think Pete showed this nicely, that painting technique. I think it does very well to use a very low energy and just paint the area with a very chaotic pattern. And depending on what I think about the patient's skin type and how much they might hyperpigment, I might increase or even decrease that setting. But you see, usually I'm usually starting around 30 millijoules.
Sure. Hey, Chad, if I could add something to that, I would say if you're just starting out here, I would stick to the microfractional, stick to DeepFX, and then as you get more comfortable, go to ActiveFX, because you're increasing the risk a bit, and you want to be a little more experienced. So a typical patient, let's say a split thickness skin graft, has some pigment change or some cobblestoning. It is a patient where you might want to treat both the range of motion and the texture and color. So the combination can be very effective. But if you're just getting started, stick to the microfractional, the DeepFX, get a few treatments, improve the function, and baby steps into the ActiveFX.
Awesome. Yeah, good point. Absolutely. You gotta start slow, the baby steps for sure. So we're going to do 2 more questions. One kind of here in a second, Andrew, I'm going to give you one about treating cutters or slashers, some of the injuries that you see there, because most of those patients are typically along the lines of in the pediatric realm. So I'm going to give you that. But first, we're going to kind of talk about the pulse dye, because there's been a number of questions on just the principles of pulse dye and the settings and those type of things. In particular, one was kind of talking about purpuric or non-purpuric settings. And I'll answer that part, and then if someone else wants to chime in after that about, in particular settings that they may kind of use in general. So to use Rox Anderson's analogy, you want to kind of tickle the scar. You don't really want to give it any purpura, and I'm much in that camp. I never ever cause or try to cause purpura in a scar in particular, because you have very poor blood flow as it is. You're going to go in there and kind of cause more purpura, which is going to get more hemosiderin deposition. And so in my opinion, you're actually potentially complicating the scar even more in the long run by adding more heme in there that's going to have to be potentially treated or resorbed. And so you just want to tickle it to kind of damage that endothelium like the PDL does. And so that way you kind of decrease the amount of erythema there slowly and methodically, and not try to cause a lot of purpura. Does anyone else have any comment on that?
Chad, if I might, I think you want to think about the mechanism of action for vascular lasers. If you're treating a port wine stain or telangiectasia and you want to destroy it, that's fine. But in scar remodeling, it appears that you're not remodeling the scar by destroying vessels. You are trying to stimulate a wound healing and remodeling response. So, generally want to do sublethal injury. For example, if you're using a pulse dye laser with a 10 millimeter spot, you might be in the 4 to 6 joule per centimeter square range, and generally a shorter pulse width. So minimal purpura. You don't want major purpura, minimal purpura. Pulse width about 1.5 milliseconds, lower fluence, maybe a third lower than you're using for vascular destruction.
Okay. So, and Andrew, do you want to go ahead and answer about the cutters?
Sure. I would. The answer is pretty easy. They're the toughest kind of scars that I actually treat. I do try. I think the approach is a little different than maybe what the focus of this talk has been. I've found that usually it's the erythema of the scar or the post-inflammatory hyperpigmentation that is the most noticeable. And that's usually what at least the pediatric patients that I'm seeing, or more specifically adolescents usually, are looking for. So my approach is to first make sure that these patients are not suicidal. And it's interesting, the literature is mixed. Many times this is actually misinterpreted. The act of self-cutting is misinterpreted as an act of suicidal ideation. I think most mental health experts would put this more in the bucket of sort of attention seeking and maybe anxiety related, but not true suicidal ideation. But I start with that and make sure you can do your depression screen and the more complex 2 to 9 question one. And I try to involve the mental health community as much as possible for that. And then I have a pretty long discussion with the patient and the parents about how this means nothing if we're still doing the behavior. So I have to get buy-in from them that this is over. And that's for 2 reasons. One, because it makes sense not to be treating active cutting. And then 2, I think that any time that you can buy is probably time on your side. So how I actually do it is I will focus a little bit on the use of the pulse dye laser to start with, to your point, Chad, tickling. That's a kind of a weird term that I don't use around children too much, but the idea that just doing light and that's totally changed, right? That's totally. I was pounding these things with 11 joules, with a 9 to 11 joules is pretty much my standard go-to with a 7 millimeter spot when I was first doing this, and I was getting purpura on purpose. But now I'm probably in the 6 joules area with either 7 or 10 millimeter spot. And I get pretty decent results there with erythema. What I've changed most with the use of the UltraPulse and the deep effects is instead of just treating the scar itself, I really kind of take the, let's say, forearm or it's often the anterior thigh or the underside of the forearm where the cutting's happening, and I will treat the entire I don't know if you can actually call it a cosmetic unit, but the whole area. I kind of very light, still never more than 5% density, but I'll treat the entire forearm multiple times sometimes on both sides, so that the finished result sort of looks more like the other side as well, which I'm not sure that's a tough scenting process. I talk a lot about big surface area being treated, high risk for infection in a group of patients that may or may not take a shower every day. I mean, it's a big buy-in sort of process, but that's been the only time when I've actually looked at it and gone, yeah, I think I made a difference. Sure. Yeah. I mean, actually, I think less is more sometimes when you're dealing with cutters. I almost kind of use my non-ablatives more so than my ablatives, fractionation wise, to, just kind of totally regenerate it, just kind of tickle it, so to speak, but less aggressive, because some of the PIH aspects of things after the ablative
can really be an issue on that back part of the volar part of the forearm. That can be a real big issue and stand out more sometimes. So, well, I would love to, continue these conversations, and because these are great guys, and they have a wealth of knowledge. I think that in the interest of time, we'll probably, cut it short. I wanted to thank Luminous extensively for putting us together, these 6 random people across the country, and the time zones and all the different communication. So Luminous was huge in organizing this, and so I can't thank them enough for this. And also the co-presenters here, what a great group. Dr. Donlin to, on the East Coast, and Bichovsky to, guys out on the West. So thank you all. I don't know if any last comments, but thanks all for joining us. And what we'll try to do as far as the questions, we'll try to get with you individually. We'll find a way to try to get your questions maybe answered individually and get them directly to you. So thanks for joining us.
Thank you.
Thanks very much, Chad.
Thanks. I would refer people to the SCAR issue,
Thank
the
you.
February issue of Lasers and Surgery Medicine. Had many of the papers featured today, including the consensus paper, the depth paper, the pre-treatment and scar prevention paper, and looking at many of the questions asked, the answers lie in some of those papers.